Discover the 2 crucial steps to take when blood pressure drops too far, too fast. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 59-year-old man with metabolic syndrome, albuminuric chronic kidney disease, and long-standing hypertension is brought to the emergency department for severe headache, blurred vision, nausea, and chest pressure. He lives alone. His medications are losartan 100 mg daily, amlodipine 10 mg daily, chlorthalidone 25 mg daily, carvedilol 25 mg twice daily, and atorvastatin 40 mg nightly. His father required dialysis after years of poorly controlled hypertension. Nickel causes localized skin irritation, and iodinated contrast previously caused transient flushing. A prior event monitor showed sinus tachycardia without atrial fibrillation. A prior skin biopsy from a chronic wrist eruption showed allergic contact dermatitis. On arrival, his blood pressure was 242 over 136 millimeters of mercury. Fundoscopy showed bilateral flame hemorrhages, cotton wool spots, and optic disc swelling. Estimated glomerular filtration rate was 22 milliliters per minute per 1.73 square meters. Normal, at least 60 milliliters per minute per 1.73 square meters. Potassium was 4.7 milliequivalents per liter. Normal, 3.5 to 5.0 milliequivalents per liter. Urine albumin to creatinine ratio was 860 milligrams per gram. Normal less than 30 milligrams per gram, and high-sensitivity troponin was 34 nanograms per liter, normal less than 19 nanograms per liter. Electrocardiography showed left ventricular hypertrophy without acute ST segment elevation. He received 2 intravenous labetalol boluses followed by intravenous hydralazine. 40 minutes later, his pulse is 139 per minute, temperature is 36.5 degrees Celsius, respiratory rate is 18 per minute, blood pressure is 112 over 37 millimeters of mercury, and oxygen saturation is 91% on room air. The calculated mean arterial pressure is 62 millimeters of mercury. He is pale, confused, and cool, with flat neck veins, clear anterior lung fields, weak peripheral pulses, and declining urine output. Lactate is 4.1 millimoles per liter, normal 0.52.2 millimoles per liter. Which immediate response best addresses the failed blood pressure lowering strategy? Option A. Stop further antihypertensive dosing, place him supine, give a 250 milliliter isotonic crystalloid bolus, and begin low-dose clevidipine when mean arterial pressure exceeds 70 millimeters of mercury. Option B. Stop further antihypertensive dosing, place him supine, give 2 liters of isotonic crystalloid over 1 hour, and use norepinephrine if mean arterial pressure remains below 65 millimeters of mercury. Option C. Stop further antihypertensive dosing, place him supine, give a cautious 250 milliliters isotonic crystalloid bolus, and use norepinephrine for persistent hypotension under continuous arterial monitoring. Option D. Give another intravenous labetalol bolus, withhold intravenous fluid because of chronic kidney disease, and transfer him for immediate catheter renal angiography. The correct answer is option C. Stop further antihypertensive dosing, place him supine, give a cautious 250 milliliters isotonic crystalloid bolus, and use norepinephrine for persistent hypotension under continuous arterial monitoring. The antihypertensive strategy produced an excessive and rapid pressure reduction, converting a hypertensive emergency into shock. Blood pressure fell from 242 over 136 millimeters of mercury to 112 over 37 millimeters of mercury, with a verified mean arterial pressure of 62 millimeters of mercury. Confusion, cool skin, weak pulses, oliguria, and lactate of 4.1 millimoles per liter indicate systemic hypoperfusion. Further antihypertensive therapy must stop. Flat neck veins and clear anterior lung fields support a cautious 250 milliliter isotonic crystalloid challenge, while stage 4 chronic kidney disease argues against indiscriminate large volume resuscitation. Persistent hypotension requires titratable norepinephrine and continuous arterial monitoring. A rapid 2-liter infusion risks pulmonary edema in advanced chronic kidney disease and is unnecessary before assessing the response to a small bolus. Restarting clevidipine merely because mean arterial pressure exceeds 70 millimeters of mercury would be inappropriate, while shock physiology and impaired organ perfusion remain unresolved. Additional labetalol would worsen hypotension, and immediate catheter renal angiography would not treat the life-threatening iatrogenic circulatory collapse. In summary, this is treatment-induced shock after excessive blood pressure reduction. The immediate objective is restoration of organ perfusion, not further pressure lowering. Small volume reassessment and vasopressor support are safer than either continued antihypertensive therapy or unrestrained fluid administration. Primary teaching point: chronic severe hypertension shifts autoregulation, so abrupt normalization can cause cerebral, coronary, and renal ischemia. Secondary teaching point: in advanced chronic kidney disease, fluid resuscitation should use small aliquots with repeated assessment, followed by norepinephrine when hypotension persists. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.